Good afternoon or good evening for some of you. My name is Rachel Bohr, and I'm EnsoData's Senior Marketing Director. I just want to thank you so much for joining our webinar tonight, 5 main takeaways from the AASM Scoring Manual updates. Shahnawaz Khan has been in the field of sleep for the past 15 years. He began working as a technologist while attending college at the University of California, Santa Barbara. The patient experience and interest in sleep caused Shahnawaz to fall in love with the field, and he became an RPSGT, moved to San Francisco, and worked as a technologist at Stanford Sleep Center. He acquired his CCSH and wanted to expand his experience working in the field. This led him to work with the BRPT on the Exam Development Committee. From then on, he has worked at various research and tech institutions and has had many years of experience as a dedicated scorer with experience in over 20 different sleep systems. Shahnawaz is currently an RPSGT clinical informaticist at EnsoData. He pioneered EnsoData's RPSGT ride-along program, in which he assists customers with a comprehensive understanding of the software, serves as a liaison providing clinical expertise in AI scoring usability, and helps bridge the gap between technologists and the growing AI scoring technology presence in our industry. And with that, I am so pleased to turn it over to Shahnawaz.
Thank you, Rachel. So we're going to go ahead and start. I want to thank everybody who was able to make it during this time. I know that there might be night technologists that, need to work, getting up for work, would probably be sleeping at this moment, but I'm happy that you're here. So this is 5 main takeaways from the AASM Scoring Manual update. I wanted to first present my conflict of interest disclosure. As mentioned before, I am an employee at EnsoData, and I won't be discussing any EnsoData products, but I will be showing some screenshots for examples from our study management platform. So here is our agenda for the day. We're going to be discussing the changes and updates to the V3 manual, including staging rules, arousal rules, cardiac rules, respiratory rules for adults, movement rules as well. And also, after we discuss all of those, we're going to go ahead and have some key takeaways, which are going to consist of how to manage these changes, some actions for the sleep labs, as well as implications of these changes towards sleep labs, techs, patients. Also, I will go ahead and discuss the significance of being up to date in the field. So the most current updates to this AASM manual are as of February 2023, which doesn't seem that recent, but still the most recent update that we have. We're going to go ahead and start with the staging rule updates. But before I begin, I wanted to first discuss briefly the 3 words that you're going to see if you open up the AASM manual. And they're very often, there's been an oversight at times when people don't really pay attention to them, but they're significant and they're important. These words are the optional, recommended, and alternative. And you'll see those quite often on different type of criteria, different type of, subsections. And the importance of knowing those is that the recommended alternative, and optional rules are all methods acceptable by the AASM for scoring. An accredited center must follow all of the rules, but based upon the discretion of the clinician or investigator, a specific center may use alternative or optional rules in the place of the recommended rule. The use of alternative and optional rules would not create any risk to accreditation. So always good to know that. All right, so one of the first changes in sleep staging rules for adults is in section E, with updated terminology for alpha rhythm, and the change is now to posterior dominant rhythm. Throughout the chapter, and added a new note to explain why this change was made, and typical ranges seen across age groups. So posterior meaning the furthest to the back, and dominant as it's mainly consisting of that rhythm. So with item 2, section E, that updated terminology, one of the designations that most technologists would observe is identifying the sinusoidal wavelengths and waveforms that are typically seen as wake to be characteristic of alpha rhythm. So as it's referenced, the reason for this change is because not all alpha wave activity is posterior dominant rhythm or alpha wave activity predominant in other brain areas. For example, in frontal and central derivations in alpha sleep, as well as the normal range for posterior dominant rhythm for adults is 8.5 to 13 hertz. And in infants, over 6 months and young children, it typically starts in the upper delta and theta frequency and will gradually increase as the child ages. So that change in terminology was illustrated so that it can show that it's not always designated in that particular region. So that is one of the changes that has been made. As you can see above, it mentions that this is the recommended setting and that the other criteria are still the same and they have not been changed. In section H, there has been a new added note with tips for correctly identifying qualifying slow wave activity due to its reported difficulty. As most people know, it's pretty hard to be able to identify delta wave activity just kind of by looking at it. For some people, this might be something that you already have done, but for a lot of people, it might be something that you may not have considered or even thought about. But what I'm referring to are these reference lines that can be added on your software as seen in the diagram above, which shows the upper limit and the bottom limit for 75 microvolts for the peak-to-peak detection of delta waves. So as you see on the top, that's 37.5 microvolts, and on the bottom, negative 37.5 microvolts to equal a sum total of 75. So by adding this, it helps to be able to identify whether or not you're seeing stage 3 delta wave sleep. So this is something that you can add to be able to help you identify that. Also, something that is introduced in the manual is the introduction of the term candidate. So in this case, candidate slow wave delta waves, where they have the possibility of meeting that criteria, but they might not necessarily be that very thing. So it's considered a candidate. So this is something that you'll see as well in the movement rules and some other type of involvement in the manual. So let's see. Moving on, we have arousal rule updates. And in this arousal rules, we have section A, which was previously a note, information about scoring arousals immediately preceding a transition to stage wake is now contained in a rule. This rule is that you must score an arousal if it immediately precedes a transition to stage wake. That is, both the arousal and the transition to wake are scored. So despite the feeling that some people might have regarding scoring arousals in wake, if an epoch of sleep has 10 seconds preceding an arousal of stable sleep, even if the epoch is scored as wake, you'll still need to score that arousal. And there's a diagram right here that kind of gives a little bit of that visual to kind of see that even though this epoch is scored as wake, you're still going to see that there's about 10 seconds preceding this arousal. So you're still going to go ahead and in that case you would mark this arousal even though it is marked as wake. And I know that there's probably some feelings about that, but this is one of the newer updates. All right, so we have some cardiac rule updates as well. And for some of these, they might not appear to be significantly different than what you might be doing in your lab, and that's wonderful. But the thing that I've also thought about is that these are widespread changes that are trying to make things easier for technologists, make things easier to identify and understand. So there might be places out there that are not or have not been privy to these changes, and there might be places that have been doing them since day one. So it's a combination of the two. So for cardiac rule updates, section A, there has been an added new optional rule about using a single modified electrocardiograph lead on the torso with an accompanying new figure and a new note. It's important to note that this is an optional rule, and the derivation from electrodes placed on the right arm and left arm with the negative electrode can be placed below the right clavicle at the mid-clavicular line and the positive electrode below the left clavicle at the mid-clavicular line as well. So instead of having it cross diagonal, you can go ahead in an optional setting, apply them underneath the right and left clavicle respectively. This is to show what currently we still have as the recommended rule under the clavicle and between the 6th or 7th intercostal space. So as you can see from the diagram, it's a little different, but this is what the current recommended application for the electrodes still is. In addition, a diagram and visual has been added to the new recommended rules in section B for cardiac, and these are for scoring the presence of first, second, or third degree atrioventricular heart block and cardiac pacemaker rhythm with an accompanying new figure and a note. So it's kind of cool that they've added this. I think it's very helpful. I think it's helpful for newer technologists as well as current technologists, people who are, feeling some type of a way about how the EKG arrhythmias are. I know that there's definitely a lot of them. I know that it's daunting. It's pretty stressful, and it's nice that they've added this in here to kind of show what you can expect to see with the duration. It shows the diagrams as well. As you can see, it shows first degree, second degree Mobitz type 1, also known as Wenckebach, and you have Mobitz type 2. You got your third degree heart block as well, and also a pacemaker rhythm, which it's important to be able to see that when you are spending time with your patient at night and you're looking, and you might not have gotten that handoff from that patient letting you know that they have a pacemaker, and then you're able to see that wavelength and be able to see that it's a paced signal. And so this is kind of showing a visual for that. In addition, they've also included an accompanied note, which is significant to note that reporting should occur if the quality of the signal is sufficient for accurate identification. Otherwise, a general description of the abnormality should be provided. I think this is something that techs have been concerned about since day one, because a part of us feel that we have to diagnose and we don't really know if this arrhythmia is this arrhythmia or that. So this is essentially letting you know that if the quality is significant enough for accurate identification, you can go ahead and report that. Otherwise, a general description, which is better than just leaving it by itself. So I believe since the nature of identifying EKG abnormality is stressful for techs, this is something that makes it a little bit more appealing. Not knowing what might constitute a diagnosis or if a tech is mistaken is something I definitely empathize with. So yeah, it's pretty nice that they've added that. Moving on to note 2, the existence of ectopic beats should be reported. So some examples such as sustained bigeminy, every other beat, trigeminy, or frequent premature atrial ventricular contractions, also known as PVCs, which everyone gets to see as an overnight tech. So the reporting of that is important, and I'm sure for some techs they've been doing it since day one, just like myself. But writing that down and reporting that is important to know. Note 3, discussing the mentioning of the use of a single ECG lead is unreliable for detecting ST segment and T wave abnormalities. Note 4, discussing mentioning of sinus rate variability in children and its reference for further information if you want to, be able to see that and see references 1 through 3. The mention of Note 5, which is important to consider, that the sustained sinus bradycardia or tachycardia is defined by more than 30 seconds of stable rhythm. And that's super important because that helps to distinguish between transient responses, sleep disordered breathings, arousals, things like that. So it's good to be able to see a sustained level of 30 seconds of rhythm before you're able to consider whether or not you're having bradycardia or tachycardia. Note 6, and lastly, some advice on helping aid the detection of atrial or ventricular pacing spikes by utilizing the high frequency filter is also added on there so that it can help aid the tech in being able to see that. All right. So respiratory rule updates. So we have an update to Section B, which was previously a recommended rule. Information about baseline breathing amplitude is now contained in 2 notes. So in Section B, previously a recommended rule, the baseline breathing amplitude should be taken into consideration the mean amplitude of stable breathing during the 2 minutes preceding the event onset. So when you're looking for that baseline breathing, you want to look at that 2 minutes of stable breathing before you're able to establish that. But of course, there's circumstances that are different in which you might see, variability in breathing, instability, and if that's the case, you want to go ahead and look at the 3 largest breaths prior to the onset of that event. In note 2, it extends saying furthermore that when baseline breathing amplitude is not and cannot be easily determined, and when the breathing variability is large, events can be terminated when there is a clear and sustained increase in breathing amplitude, or in the case where desaturation has occurred and there is an event-associated resaturation of at least 2%. In addition to that change, in Section D, which was previously an acceptable rule, the scoring of hypopneas using a 4% oxygen desaturation from pre-event baseline has now been changed to optional. I think I have a visual of that. And so, as observed on the slide, the scoring of a respiratory event as a hypopnea still consists of a peak signal excursion drop of 30% pre-event baseline using nasal pressure, PAP device flow, or an alternative hypopnea sensor. So this can consist of a nasal thermistor, a thermocouple, and the duration is still the same of 10 seconds. And of course, the only difference between the 2 notes, 1A and 1B, is going to be that 4% O2 desaturation from pre-event baseline. Also, they've added a pretty cool little picture and diagram, which is more related to PAP device triggered breaths. So before I even start saying anything, if people are kind of looking, if you look at that 4th signal channel, it's something that's very important to kind of see what's going on here in regards to like, what is this event? It's a central event, and sometimes I think I showed this to a couple of people, and they're saying over here, I don't know if you're able to see my mouse, but there's a little bit of effort in that abdomen belt, so they're like, maybe it's an obstructive event. But in reality, it's not, because in this case, they're using a modality such as bilevel ST, in which they have a backup rate where the device is forcing them to be able to take these breaths. So these are machine triggered type of breaths. So this right here essentially is a complete cessation of breathing, but they're trying their very best. So in this case, with the marking of this type of event, you want to be considerate of observing whether or not they're having an event relative to a machine triggered backup rate. So pretty important to see, because upon just first glance you might not see it, but after you review it you'll kind of have an idea of that. So these little blips essentially kind of look like pacemaker marks, but these are the little forced machine breaths that are happening. So furthermore, the criteria for scoring respiratory events using a backup rate are as follows: a decrease in PAP flow signal meeting apnea criteria, right? So something like that. Device triggered pressure pulses, which are pressure support occurring during the event. So these guys right here. And there's no evidence of spontaneous patient triggered respiratory effort during the event. So that's the change that has been added, or the addition of this diagram. All right, so another change that has been added has been towards the movement rules, one of my absolute favorite ones, PLMs and movement related things. So in section B, there's been an update to the terminology for significant leg movements. Significant has now been changed to candidate leg movements, and you'll see it throughout the chapter. Specified that at least a portion of a candidate leg movement must occur in an epoch of sleep. And once again, like I mentioned earlier, the significance of how the term is being utilized as candidate is that this LM is not necessarily a part of a PLM series yet, but it's a candidate. It's applying to see if it qualifies. So in the movement rule updates, the updated terminology for significant has been changed to candidate. So as seen in the criteria, the same duration is happening, the amplitude's the same, the timing of these candidate movements are also the same. Previously, the scoring rules for the additional change that has been added is in section F. Previously, scoring rules for alternating leg muscle activation, hypnagogic foot tremors, excessive fragmentary myoclonus were in their own sections, but now they have been combined into one section, and that section is called Scoring Other Movement Disorders. All right. So there are some minor changes. I didn't feel like it was something that I could discuss in depth because some of them are minor verbiage changes. Some of them are tiny little assessments. So this is we have gone through a majority of the changes, but here are some extra features. So we have home sleep apnea test HSAT rules for adults, part 1 and part 2. This is part 2, utilizing peripheral arterial tonometry. So previously, it was a recommended rule. Reporting the oxygen desaturation index, the ODI, was changed to optional. For parameters to be reported, part 2, with rules for reporting MSLT and MWT, there's been a new section added, which includes reporting rules for the MSLT and for the MWT. For parameters to be reported in part 1, rules for reporting polysomnography, section 10 has been updated with the rules reporting the highest and lowest heart rate during sleep and recording is now optional. Section F has added new rules that reporting the central apnea index is optional and reporting time below significant oxygen saturation threshold is recommended. This was previously optional. Reporting the occurrence of snoring in children was changed to recommended. And one other change that I recall is for oxygen, for meeting oxygen criteria for supplemental oxygen, it is one of those things where it is essentially the clinic or the medical director protocol and what their discretion is. So that is the another adjustment that has been made. All right, so we're going to go ahead and take a quick look at some of the key takeaways from some of these changes, as well as just the overall macro perspective of changes done in the field and in AASM manual changes that have been made recently. These 5 takeaways are going to be how to manage change, actions for sleep labs, implications of changes for sleep labs, techs and patients, outreach, and being up to date in the field. So starting off with how to manage change. There will always be progression and changes and updates to the field. The field's constantly changing. I'm sure that some folks here who have been in the field for over 20 plus years have observed some of these changes and can agree to this testament. Because of this, we will continue to have opportunity to adapt to these ever-growing changes and the updates and changes to guidelines, which can change from mediation, research and advancement, technological advancement as well. So these are important for us to allow this adaptation. Our protocols, it's important because this is how we can influence changes in lab protocols as well as protocols governed by the AASM and other organizations in sleep. It's important that we as sleep techs, lab managers, physicians, stay on top of these changes, and effectively demonstrate and incorporate them into our lab protocols. Having protocols and being up to code is not enough, unfortunately. We need to make sure that we are properly adopting and implementing these protocols into our practices and making sure that everyone is abiding to them to the best of our ability. Lastly, education. Education is fundamental and an essential component to garner a complete transparency between all staff, technologists, clinicians alike, who are part of the day-to-day tasks in our labs and in our field. I think it's super important because this type of exclusivity of information in a field that's designed to help advance, to help treat people, to figure things out that haven't been yet discovered, it's not helpful to keep things exclusive in terms of if you're a tech and you know something cool and you want to, talk to your colleague about it. It's something that can help advance things and move things forward, even if it seems small and menial. So understanding the rules and regulations can help create a consistency and a continuous rate of growth, and is something that we can do that is doing right by our patients and the ones who come to us for help, treatment, and guidance. Next up, necessary action items for sleep labs. Moving on, here are some action items that sleep labs and staff can do to assist in garnering a successful future. Staying current. Understanding what's going on in the field of sleep is extremely important, and being aware of the changes that are happening within the field, even as far as understanding new technology, growing companies, etc., can be valuable in seeing the direction that the field is going, as well as the direction that it very might well end up. Asking questions. I feel like this action item might be a bit superfluous, as most technologists, at least the ones that I've met, are quite outspoken. Nevertheless, I believe there is some value in curiosity and expressing that curiosity to the people that you work with. Try your best to engage in conversation and query with the doctors at your lab, with your lab managers, your lead techs. Reach out to the BRPT and the AASM as well, as anyone who you'd like to learn answers from. The reluctance and abstinence of asking questions will only hinder our individual, collective, and overall growth in this field. So this brings me to something very important that I want to express to the technologists out there, the night techs, the day techs, all of you guys. Experience, so knowledge exchange, that's what I want to discuss. Experience is a valuable and important asset in life and in the professional setting, particularly in this field. Folks with experience working with multiple systems throughout the span of their career are invaluable in their understanding in this field. But this doesn't mean that you're done learning. I respectfully beseech people to start sharing your knowledge with your coworkers. Don't gatekeep information. Some of these new techs are very hungry to learn from the well-polished OG technologists that they work with. They might also surprise you. You might be able to learn something from them that you might have not known, or something that is new that has just been applied that they know about that you have not experienced as well. The exchange of knowledge can help bridge the gap between information and expertise that otherwise could not be found in the same time frame. It also can help create a bond and form a closer relationship among each other in the sleep field. It's only something that can benefit you. So our third takeaway, implications for changes for sleep labs, techs, and patients. So protocol updates and changes. There are continuous changes that are updated in the manual, and we have continuous version updates. So without adhering to these changes or being aware of these changes, knowing that they've happened at all, it can result in skewed metrics. Reporting numbers and calculations might not be representative of these updated changes. And without staying current, this can impact and affect important things for patients who need to meet certain criteria for titrations, different criteria, for limb movement series, things like that. So it can really skew and affect those things that we're doing for our patients. And this can result in potential differences for those patient results. So due to changes in characteristics in staging, respiratory settings, and rules, things that are acceptable, are recommended, were recommended, are optional, were optional. These are all important things to stay on top of. And like I said, they can result in different clinical outcomes if not following those current guidelines. Sleep labs can face scrutiny if applications and testings are not followed by the updated results. This highlights the significance of being up to date with current guidelines, especially important if labs are seeking accreditation or are continuing to be accredited. And the AASM guidelines have been a staple for consistent lab use, and it can reflect on collaborations and reputation as well. I mean, I know that there has been times where I've known people and they, wanted to get a sleep study done and a lab wasn't accredited and they didn't want to go there for that reason. So there is a level of, you know, reputation that follows that as well. As such, it's important to make sure that there are not changes in practices that might be outdated. There might be policies that haven't been updated since 2008. So sleep labs might be operating under these policies. So it could be due to an oversight. It could be due to lack of education, exposure, and that can prevent awareness of changes. It's important to try to be part of, the ASM mailing list, mailing lists of any type of organizations, just to keep up to date with the AASM manual and its updates. Excuse me. And last but not least, we have two other takeaways: outreach and being up to date in the field. So the last two takeaways are these: the importance of outreach, the importance of being up to date in the field. Some of the things that you as members of the sleep community can do is be more inclusive in your sleep community. Attend webinars. You got that one right. Much like you're doing now. Visit websites for different sleep societies, local sleep societies, state sleep societies that might be throwing conferences. Join their mailing lists. Be aware of when conferences are being held in your state. Try to attend these local conferences. If your organization pays for an educational fund for you as an employee and you have that opportunity, try to take advantage of it. The networking and the exposure that you have at these conferences allow for a wonderful opportunity to not just learn and advance, but to also become more well known in the field and have the ability to impart change. Lastly, volunteer with organizations like the BRPT, the ASM, AST. These type of involvements can really change a lot of things, and they can really change the way that our field exists as it is now. I want to leave you with a personal story that is very much reflectant of what I'm discussing in these last items. So when I was a young tech, I remember that I had the opportunity to be able to go and get a job at Stanford as a sleep tech. And my exposure to anybody in sleep was just my colleague, my manager, and maybe 3 people that I met 5 years ago at a conference. So I didn't have that much exposure. So I didn't really know many people in sleep existed. I didn't have a lot of resources to be able to find people online, anything like that. So I was kind of, held back in that way of knowing that anybody else was really a sleep tech. I thought I was the only one there. So luckily, I was able to get some educational funds put together, and I was able to attend the BRPT annual symposium, which was in Portland, Oregon at the time. This was my first official conference, and I was very excited to be able to learn from the best of the best and be with my community. So naturally, I was very excited to go, attending the lectures, speaking to the technologists, learning about different physicians, about different practices from all different walks of life, and kind of feeling that excitement that there are other people like me out there, and people who, have been doing this for much longer, that have experience that has gone way beyond my own measure. I recall I was able to see a registration for a workshop that I wanted to attend, which was exam writing questions for the RPSGT exam. I attended the workshop and was completely enamored with the ability to be on the other side of the coin, and my memories of how difficult it was to get the RPSGT licensure suddenly had put me on the other side of that seat, and it was really nice. And I was very excited. And at the end of the workshop, I remember I was approached and offered the opportunity to write exam questions in San Antonio with the BRPT CDC Exam Development Committee. And not 6 months later, I was there. I was very humbled and honored to be around renowned and reputable members of the sleep community and the BRPT, and able to effectively give my thoughts and opinions towards questions and contribute in a way that I had never even imagined before. And this kind of allowed my sense of community to continue to grow and grow. And I met a wonderful amount of people that became my friends and part of my cohort as well. After that, the excitement and the interest kept growing and growing. I was able to be a part of the board of directors for the California Sleep Society, continuing to try to make some efforts and changes and voice my opinion. And since then, I've been very blessed to have been connected with members of the sleep community from the entire country, and even recently was able to go and be a part of the RPSGT and CCSH job task analysis with the BRPT. So I want to signify that this story's purpose is to drive the point that there was nothing special or targeted in the ability to network with my community. Our field's full of wonderful people who want us to be able to contribute and make changes and participate. And they're very open to that, but we have to go ahead and make the desire and that effort to do so. So our field is ever growing and will continue to grow faster and faster, but we have a unique opportunity to be a part of a change that can affect the future. So I appreciate that you came out here to listen to these changes and these takeaways. And with that, I will leave you with one last lovely poll question. Have you implemented any changes in your organization as a result of the scoring manual updates?
All right, let's share the results. And then do you want to read what some of the folks have put into the question panel as far as what they have done?
I think you can share them.
Okay, I'll read through them and then we'll go to questions. So if you have a question, please feel free to put it in the question panel, and then I'll read what some of the changes that have been incorporated are.
And before we,
Oh, go ahead. Sorry.
sorry, Rachel. I just wanted to share with the audience that it looks like we have a majority of people that have not implemented these changes. So I do hope that this has been helpful in seeing some of those changes that can be applied. And back to you, Rachel.
All right. So one change is we changed the wording on how we scored hypopneas from alternative to optional. Implemented the addition of delta marker lines, a new arousal rule, reporting 3 and 4% DSATs, educating staff on insurance guidelines, stop text from scoring at night. All scoring is done by one dedicated scorer, me. We've updated our reports and terminology, and scoring 1A and 1B rules. And I think that's all the feedback. But we do have some questions if you're ready to roll into that.
Yeah, sure.
Okay, let me close this poll. All right, so first question, how do we handle texts that refuse to adapt?
Got some existential questions. I mean, I feel like I can try to answer in the best of my ability and more along the lines of kind of channeling how I would feel in those situations when I was exposed to that direction. I think the thing about it is trying to first understand what the core reason for the resistance is, because I don't firmly believe that people are in this field because, or they're in this field without wanting to do right by their patient, right? I think for me at least, the driving factor of everything that I ever did at night was for the patient. We hopefully can agree upon that everything is for the patient. So understanding the tech's perspective, I think in a lot of cases, night technologists, I'm thinking of night technologists particularly, have a hard time communicating and being able to be heard because of the very nature of the shift. The main people that are there to listen to the night technologists are the patients and the techs, and it does it is hard. So I think understanding what the resistance is about and kind of trying to work with them to work together and figure out what they can do is essential. So I think not just enforcing, but understanding is something that I would feel heavily on. I respond to it a lot better as a tech if I was if I had the autonomy, if I felt empowered that I actually had some input as well. I'm
What
not sure.
hypopnea's rule changes in diagnosis of sleep apnea patients? Was there a hypopnea rule
I think the
change, maybe?
hypopnea rule change was the 4% as an optional.
Mm.
So the recommended is still there. The optional has been changed. So based upon your lab and its criteria, I think the diagnosis would change relevant to whether or not you're scoring 4% or 3% per Medicare or per your institution that you're working at. So that would be the only change that I could imagine.
Let's see here. This one too. I think, Elizabeth, I think you're asking for a confirmation of, and I am not good at pronouncing these sleep words sometimes, but tachycardia in sleep is 90 BPM and bradycardia is 40 BPM. Is that accurate?
I will have to take a look. That is something I you can access on your manual, but I believe it is. Um, my brain keeps saying 100, but I think it is 90 for tachycardia and 40 for bradycardia.
Okay.
It's hard. Sometimes it's hard because you should utilize your ASM manual as a reference guide because I have been looking at the manual since 2007 and it has been ever changing. So sometimes my brain accesses different editions of it.
And Nadina, thank you, has chimed in. Yes, I have it memorized. So thank you for that. Thanks for chiming in there. All right. Will the new rules apply to HSTs or are there separate takeaways for HSTs?
There was a change for HSTs, but I believe that those changes um, have not changed significantly for HSTs. I think the only difference was with the tonometry um, displaying of the ODI that has been adjusted, but not the rules that we discussed. Those were specifically for the PSGs, I believe.
Oh, Laura. Laura's actually provided some clarification for hypopnea too, if you'd like me to read that. Thank you, Laura
I
Lindley.
I love it.
Love the participation. This is fantastic. For scoring of hypopneas in version 3, the 4% rule was changed from acceptable to optional. Therefore, AASM accredited sleep programs are required to report the 3% rule for all studies and can optionally choose to also score studies using the 4% rule, like if they need to do so as part of a pay requirement for reimbursement like Medicare. Only using the 4% greater than 4% criteria would not meet accreditation requirements since the greater than or equal to 3% criteria is what is recommended. So from an accreditation perspective, the 3% rule becomes required to report despite the insurance the patient carries, while the 4% rule is now optional to report. Laura, thank you so much for chiming in on that. Appreciate that. Is there anything you wanted to add, Shahnawaz?
No, I'm actually I'm very happy at seeing the confluence of people speaking to one another. This is really nice.
I think this was one of your points, right?
I really like the conversations between one another.
Yeah, knowledge exchange.
Yeah, I really appreciate it, and I appreciate everyone that's hanging out and spending time.
Um, and thanks again. Thanks for sharing your time with us today and just for participating. This has been fantastic. Shahnawaz, do you have any parting words that you'd like to share?
Let's keep going. Let's make some changes. This is a it's going to be a great time to make those changes. And thank you as well, Rachel. You are an awesome co-pilot.
Thanks. Well, I hope everybody has a wonderful evening. Take care, and we'll see you on the next webinar.
Thank you. Bye bye.